Good afternoon, and thank you for the very nice invitation. And it's really a great pleasure to be here in Beirut, in Lebanon. I had an hour free time this morning, so I was walking downtown Beirut, and I really loved it. Especially if you, for example, see this is more or less the weather we have now in the Netherlands. So you know, it's really great to be here, and especially Professor Sarkis, thank you for the invitation. So we'll talk this afternoon about heart failure. Last year the new heart failure guidelines were presented. We presented that at the ESC heart failure meeting in Italy, and I think there have been quite some changes in the guidelines, and I would like to highlight with you the changes in these guidelines. And as you can see here, the following topics I would like to discuss with you: the role of a gray zone, the HEF heart failure with moderately reduced ejection fraction, the HEF MREF, opposite to the HEF REF and the HEF PEF. What's that new kit? What should we do with that? What's the position of the ARNI, or valsartan sacubitril, and Entresto? I think it was. I think also the people really looked forward to what would be the position from the ESC for this new drug. I will discuss that with you. Also more device interventions. What about CRT? When should we use it? When should we definitely not use it? A few slides on neurostimulation. There have been some larger trials with neurostimulation, with vagal nerve stimulation. I'll talk with you about the new algorithm in the guidelines in acute heart failure, and then I will finish off with intra-aortic balloon pump, ECLS, and left ventricular assist devices, and also discuss a little bit with you the experience we have in my center in the Netherlands. So 3 subtypes of heart failure. In the 2012 guidelines, it was heart failure with reduced or preserved ejection fraction, and it was always the talk about what to do with this gray zone. As you can see, heart failure with reduced ejection fraction is very clear. Most trials have been done with heart failure with reduced ejection fraction: ACE inhibitors, beta blockers, MRA, ivabradine, and Entresto. And I think also quite some trials have been done in HFpEF, like the CHARM preserved, for example, the TopCat with spironolactone. But there was always this gray zone with patients with ejection fraction between 40 and 50%. And you would not call that with a preserved ejection fraction. I think if your ejection fraction is 42%, you would not say to a patient, well, you have a normal or preserved ejection fraction. But they were also kept out of the trial. So that's the reason why we clearly defined the moderately reduced ejection fraction between 40 and 50%. And it's a large proportion of patients, like 10 to 20% of the patients are diagnosed with heart failure with moderately reduced ejection fraction. And as you can see here in this slide, it really does matter if you're in that gray zone, because, for example, here this is a sub-study from the TopCat, spironolactone in patients with ejection fraction above 45%. And as you can see here, this is the hazard ratio for the primary outcome, as you can see here, with the 95% confidence intervals. And as you can see, the lower the ejection fraction, the more likely you will benefit from the treatment. So if we would draw here the group of heart failure with moderately reduced ejection fraction, this area, they might benefit from treatment with spironolactone, for example. And I think also the work we did before, also with biomarker-wise, I think that the patient with ejection fraction 40 to 50%, they resemble more the REF patients than the PEF patients. So the justification for this introduction of this new term, I think it also had some, there was some discussions about it. Should we do or should we not do it? But there is really a gray area. We do not have right now any treatment options for these patients. Like, they haven't been studied, and we just extrapolate the REF data we have. And I think identifying this as a subgroup will stimulate further research in this substantial group of patients. Well, then we come to the new treatment algorithm, still also from the 2012 guidelines: ACE inhibitors, beta blockers, MRA, class 1A drugs. And also, as you can see here in the treatment algorithm in the new guidelines, still class 1A drugs, ACE, beta blockers, and if the ejection fraction is still low, add an MRA. And then, I think that's the real new part in the guidelines. If they are still symptomatic, then there are a few options, and I will discuss with you the different options you would have once a patient has been treated with the 3 class 1A drugs. And then we're really facing a difficulty in the guidelines, because normally, as you can see here, most of the time drugs were added to the drugs patients were already using. For example, seniors, nebivolol was added to the treatment in old elderly patients. For example, the shift ivabradine was added to an ACE inhibitor and a beta blocker. Emphasis was eplerenone was added to an ACE inhibitor and a beta blocker. So it was always quite easy. So if it would be useful, if you reduce morbidity, mortality in these patients, you would just add it. And I think also from a guideline perspective, you would just follow the road, and if it's successful, you add it. But now, with this paradigm trial, I will show it later to you, the Entresto or the valsartan sacubitril, it replaced a class 1A drug. So how should you deal with that? So you have a 1A drug, a lot of evidence for ACE inhibitors in patients with heart failure, and all of a sudden there is a new drug replacing that drug. So how should we position it in the guidelines and in the algorithm? And that was we had great discussions about it, and eventually we came up with the algorithm I will later on show. So first, a few background slides about what is a valsartan sacubitril. Well, it's a combination. On one hand, in heart failure, you have the natriuretic peptide system, which is beneficial. So, of course, like BNP is a marker of disease severity, but in itself, like a natriuretic peptide, is a useful peptide. It reduces blood pressure, it reduces sympathetic tone, it induces natriuresis, etc. On the other hand, you have like the sympathetic nerve system, which is activated, and you got the RAS system, which is activated. So beta blockers for the sympathetic nerve system and RAS inhibitors for the RAS system. It has been tried before to add a neprilysin inhibitor, so to prevent the degradation of these peptides. And in this case, it was omapetrolate. The neprilysin inhibitor was merged with an ACE inhibitor, and it was quite successful. There was superior reduction in blood pressure. However, and that was the reason why the omapetrolate drug was not further developed, there was more angioedema, 2.2% versus 0.7%. So much more angioedema if you combine neprilysin inhibitor with an ACE inhibitor. Well, next from this, oops, this goes too fast. Next from this, the valsartan sacubitril, the ARNI, so the neprilysin inhibitor was hooked up with an angiotensin receptor blocker, and this is really the design of the paradigm trial. Probably you've seen that before. Large trial with more than 8,000 patients, and I think the design of the trial is very important to understand also the algorithm in the guidelines. So patients had to be able to tolerate 2 times 10 milligrams of enalapril. If they were able to tolerate it for 2 weeks, then they were all patients were receiving Entresto at the lower dose, and then receiving Entresto at the highest dose, 2 times 200 milligrams. And if they were tolerating all these steps, then eventually they were randomized. So patients had to have an ejection fraction below 40%. NT-proBNP should be elevated around 600 picograms per mil, and they should be stable on ACE and ARB and beta blockers. So this is the flow diagram of the trial. So first, all patients entered the study were more than 10,000, and 1,100 of these patients, so more than 10%, actually did not make it to the next step. So they were unable to tolerate 2 times 10 milligrams of enalapril. So they had adverse events, they had abnormal lab values, for example, renal failure. They were not willing to participate anymore, or unfortunately, they already died in the first weeks. Then all patients were entered to the open label Entresto part. Also again, around 1,000 patients dropped out because of adverse events, and then you continue with the patients who were able to tolerate both drugs, and then they were randomized. Here are some baseline characteristics. Relatively somewhat younger population than the usual HEF-REF trials. It was a global trial also running in South America, Africa. and you can see clearly elevated anti-proBNP. And background therapy with beta blockers was very high, more than 90%. But as you can see here, the use of ICD and CRT was relatively low, probably also to do with the global recruitment of the patients. Well, as you know, very effective drug. So there was an absolute risk reduction of around 5%, translating in a number needed to treat of 21. So 21 patients need to be treated for the duration of the trial, around 3 years, to prevent one primary endpoint, which was heart failure hospitalization or cardiovascular death. Also, if you look at the separate endpoint, death from cardiovascular causes, there was an absolute 3% reduction, resulting in a number needed to treat of 32. So highly effective drug to replace an ACE inhibitor. And here you can see some of the safety endpoints. Hypotension was relatively more often seen with valsartan sacubitril. Severe renal failure less compared to an ACE inhibitor. Hyperkalemia less often observed, and also angioedema, which was very closely monitored, was not very often observed. Numerically more, 10 versus 5, but statistically not significant. So the conclusion would be also from the guideline perspective that LCZ696 or Entresto is recommended to replace an ACE inhibitor if they are tolerating an ACE inhibitor. So that makes it as a second line treatment. So once the patients are tolerating ACE inhibitors at a certain level, at a high dose, then they can be switched. And that's also seen here in the next follow-up of the guideline algorithm. So the patient has a low ejection fraction and they are able to tolerate an ACE inhibitor or an ARB, then the ARNI is a class 1B indication to replace the ACE inhibitor. So later on I'll come to the CRT part. Ivabradine, a 2A recommendation if the patient is, of course, a sinus rhythm, not helpful in patients with atrial fibrillation. A 2A in the indication for ivabradine in these patients. And clearly to demonstrate that these treatments above may be combined if indicated. So if the patient has a broad QRS, LBB, they are tolerating ACE inhibitors, and they have a fast heart rate, sinus rhythm, well then you could theoretically give all three options. So few data on does the background of an ICD have an influence on the effect of the drug? Well, there is no interaction. So if the patients do not have an ICD or do have an ICD, the drug is effective in both groups. As you can remember from the previous slide, only 15% of the patients had an ICD, so the numbers are quite low, so leading to a large confidence interval. But there is no interaction between the patient having or having not an ICD. And also, if you look at preventing sudden cardiac death, 85% of the patients did not have an ICD. The use of valsartan sacubitril also significantly reduced the risk of sudden cardiac death and relative risk reduction of 20%. And the same is true for death due to worsening of heart failure, also significantly reduced with the use of valsartan sacubitril. Also, the hazard ratio around 80%. So coming to the recommendations, so diuretics are recommended. Almost no trial, mostly observational data. It's a class 1, of course. It's unsure whether it would reduce the risk of heart failure hospitalization. The ARNI, a class 1B recommendation, and the ivabradine, a 2A recommendation if the heart rate is above 70 beats per minute and the patient is in sinus rhythm. I think it's very important if you're switching an ACE inhibitor to an ARNI that there should be a 36-hour washout period for the ACE inhibitor. So it's not like the patient takes the drug and you prescribe it and the same day the patient is taking the Entresto. So there's need to be a 36-hour washout period of the ACE inhibitor because of the risk of angioedema, what we know from the omipatrolat studies. And I think it's also important, at least it's what I'm doing and what we're doing in my center, is that we write down also for the GP, like, do not combine it with an ACE inhibitor, because like there are so many new fancy drugs with new names. I think GPs or also other specialists in the hospital, they're not that aware of all the new options and they don't know the drug. So clearly state do not combine with an ACE inhibitor. That might not be a good idea. So switching gears, what about device therapy? Cardiac resynchronization therapy is recommended. Patients with HFrEF, ejection fraction below 35%. It's 35 because that's really the cutoff in the trials. Especially in patients with sinus rhythm, the evidence in atrial fibrillation is much less. QRS more than 130%, and especially in patients with left bundle branch morphology. It is contraindicated in patients with a QRS less than 130 milliseconds. I think this is a little picture. We wrote an editorial. If you talk about the placebo and the sham effect, if you think about endpoint definition of trials, and I will also discuss it later with you, the vagal nerve stimulation trial, if you do an operative procedure or device implantation, there might be a very large placebo effect, but also the patient acceptance is much higher. The patient is more willing to accept one time a procedure than being on oral daily medication, perhaps. So devices are a good option, of course, for patients with heart failure with, in this case, reduced ejection fraction. A little summary of when should we do the CRT in patients. So here you see an individual patient meta-analysis presented by John Cleland and also published in the European Heart Journal. All Medtronic trials were put on in one data set, and on the patient level it was seen, well, is there a benefit of the treatment? Here you can see the effect curve. On the x-axis, the QRS duration, and on the y-axis, the hazard ratio for CRT to prevent mortality. And as you can see clearly here, if your QRS is less than 130 milliseconds, you're actually doing worse if you get a CRT implanted. So there's a clear no if your QRS is below 130 milliseconds. On the other hand, if your QRS, and here you can see the 95% confidence interval, if your QRS is above 150 milliseconds, then there's a clear yes, you're benefiting from the treatment. And then we have really have a gray zone between 130 and 150 milliseconds. We do not have that much evidence what would be wise to do there. If there is a left bundle branch morphology, it's, we give it a class 1B. That was also the inclusion of most of the trials. If it's more than 150, I think the evidence is very strong to do it with LBB morphology. If there's non-LBB, a small minority of the patients in the trials did not have an LBB morphology, then the evidence is much less strong. So 2A if it's above 150 milliseconds. If it's between 130 and 150 and it's a right bundle branch, well, in certain cases you could consider it, but in general it's not advised. Here's a slide about neuromodulation. In the last 5 to 10 years, neuromodulation like vagal nerve stimulation has been investigated as an option, as a device therapy. There were two larger trials done. The DEFEAT study, which looked at spinal cord stimulation, so spinal cord stimulation at the thoracic level to stimulate the vagal nerve. As you can see here, also in my hospital we participated in this trial. Here you can see that the stimulator is here in the back. And here you can see the neuromodulator put in by the neurosurgeon, and here giving the therapy. Patient also has an ICD, as you can see here, with a CRT, with a LV lead. That was a DEFEAT trial. The other trial we've been doing together with the neurosurgeon. So the neurosurgeon puts here the vagal nerve, the cuff around the vagal nerve in the cervical region, as you can see here, and we put the RV lead to monitor the heart rate in order, if you give the vagal nerve stimulation, you could clearly see it. So once we put everything in place and you start stimulating the vagal nerve, heart rate really goes down. So monitoring the heart rate, therefore we needed the RV lead. So here you can see patient quite well wired up. So the idea was to stimulate the vagal nerve to induce the parasympathetic system and reduce the sympathetic nerve system, but the results have been very disappointing. There were some suggestions in smaller phase 2 trials that it might have an effect on NT-proBNP and also on 6-minute walk test. Most of the time, these procedures, they were open label, so there's a large placebo effect, which you've seen also in a few slides before. So this is the proper done trial. It was open label, but the endpoint was heart failure hospitalization and cardiovascular mortality. And as you can see, the lines are really superimposable. So vagal nerve stimulation for now does not seem to be that promising in patients with heart failure with reduced ejection fraction. And similar data was seen with the spinal cord stimulation. So this also led to the device treatment. So in the guidelines, we do give recommendations for the ICDs and the CRTs, and there is not enough evidence to support guideline recommendations for other therapeutic technologies like baroreflex activator therapy, vagal nerve stimulation, etc. I think now, because the Innovate trial was published after the guidelines, I think we can now also say that vagal nerve stimulation does not seem to be very promising. Few slides on acute heart failure. We came up with a new acronym in the guidelines, also to make it easier if you get in a patient with acute heart failure. The CHAMP acronym to think about coronary syndrome. Is there a STEMI going on, non-STEMI? Is there a hypertensive emergency? Are there arrhythmias which play a role? Is there an acute mechanical cause or pulmonary embolism? And if you identify one of these causes, of course the treatment is completely different than when a patient comes in with, let's say, normal acute heart failure. This is an algorithm. Patient with suspected acute heart failure, well, cardiogenic shock, that's a different area, of course, is a respiratory failure, non-invasive ventilation, BPAP, or eventually mechanical ventilation. If that's not the case, transfer them to the ICU or the CCU and identify the CHAMP, reversible causes, and treat specific the causing problem. And if not, then do the diagnostic workup to confirm acute heart failure and start the treatment. Here you can see another algorithm to guide clinicians. Is the patient wet and warm? The typical 90% of the patient with acute heart failure coming in wet and warm. More the vascular type, the HFpEF coming in with hypertension, vasodilator and diuretic. If it's more the cardiac type, more often HFrEF and the congestion predominates. Diuretics, vasodilators. I think we're very strong also to promote vasodilators in the guidelines. And ultrafiltration if the patients are diuretic resistant. On the other hand, if they're wet and cold, the most difficult cases, patients with very high mortality, depending if the blood pressure is below 90, inotropes are indicated, vasopressors perhaps, diuretics, and consider mechanical support. And I will later on come to the part about mechanical support. What can you consider in these most of the time crash and burn patients? If the blood pressure is above 90, then low-dose vasodilators, diuretics, and perhaps inotropy if they're refractory. So these are this is a very beautiful review from Holger Thiele, who did also the intra-aortic balloon pump trials, the SHOCK 1 and SHOCK 2. I will later come back to that. So what are the options? Revascularization clearly has a benefit, like early revascularization. Vasopressors, well, we know from the SOAP trial, no placebo group included there. Patients with all types of shock were allowed. Most of them, they were septic shock, but there was a small proportion of the patients who had cardiogenic shock. In that trial, noradrenaline was compared with dopamine, and noradrenaline did better than dopamine. Dopamine led, as perhaps suspected, more often to arrhythmias. Here we look at the IABPs. So before the IABP shock trials, I think was considered a class 1C or a 2A recommendation, but eventually the IABP trials did not show a benefit in patients with cardiogenic shock, and has mostly been abandoned in the treatment. Selected cases, I think there is still an indication. So what are the indications for left ventricular assist device, LVAD? Clearly end-stage heart failure is needed. They have to be in class 4. And these are the patients who are referred for, like, in a relatively stable condition. So they're not hospitalized at this moment for acute heart failure. So if possible, perform a peak VO2. Less than 12 would qualify, or less than 50% than predicted. So if the patients are very young, then less than 50% than predicted would also qualify. And they need to be on optical medical therapy, including devices, of course. And there should be no alternatives. And the patient is motivated for this treatment trajectory because it's a very long, difficult trajectory with most likely very often some setbacks. And I will come back to that later, what these setbacks then are for these patients. This is the principle. The cardiac surgeon puts in the left ventricular cannula in the apex. This is the VAD, and it pumps it back into the ascending aorta. So what are the possible indications for VAD support? Most often it's used as bridge to transplant, so the patients are put on a transplant list, so they're eligible for transplant. Because of the shortage of donor hearts, there's a long, in the Netherlands there's around 4 years of waiting list if you're on the regular list and not on high urgency or international high urgency. It's bridge to transplant. But also destination therapy that has been abandoned for a while in the Netherlands because of the reimbursement issues. But since 2 years, also the insurance companies allows us to use LVADs for destination therapy. So this is becoming a much more prominent area now for us. It's sometimes you do a bridge to decision that you don't know where you want to go, where the patient will go, and sometimes bridge to recovery. For example, like patients with peripartum cardiomyopathy, which have like a 50% rate of for example, recovery, myocarditis perhaps. So these are the Intermax criteria. Class 1, Intermax 1, the crash and burn, very low survival rates there, and that goes up to sliding fast, stable on inotropes and the frequent flyers. Patient coming in with acute heart failure very often. Here you can see also the summary of it. So all of them are in class 4, so it's actually a subdivision of patients with advanced heart failure being in class 4 from crash and burn, and these are typically not the patients good for an LVAD. So there are other options for these patients, but an LVAD does not seem to be the best option. The LVADs we're putting in are class 2 to 4. So progressive decline, the sliding fast, they can be stable for at least a few days, stable but inotrope dependent, so they're hospitalized and recurrent advanced heart failure. So I think most patients we're doing are in Intermax 4. And if they're class 4 and they're really housebound, that might be an option that they would qualify for an LVAD. Walking wounded and the class 3 would not be yet there for a VAD. Clearly some contraindications, life expectancy less than 2 years from extra cardiac disorders, of course, severe irreversible RV failure, BiFADs, we've never done it in my center, also because one of the other centers in the Netherlands who did it few times had very bad outcomes with these patients, so they also abandoned like the BiFAD option. Also psychosocial factors, patients need to be taken care of them, they should be compliant with medication, anticoagulation for example, pump thrombosis has been seen quite often, especially with the HeartMate 2. Well, extreme over or underweight is a problem, and if they're in Intermax 1, then the crash and burn patients we're not doing, and it might be better to put in extracorporeal life support, ECLS, in these patients with veno-aortic support, as you can see here, the ECLS, which we do give on the intensive care unit, also as a bridge to decision whether we should go for an LVAD, yes or no. So these are the 3 generations. The first were the pulsatile. Idea was what the body needs, like the pulse of the regular heartbeat, so to speak. But the problem is, like bioengineering wise, that a pump is very pulsatile is very difficult to make and is very vulnerable to damage. So the second generation was an axial pump, as you pump water out of, well, we're very good at that in the Netherlands with the high water and the sea. So pump out the water from the sea to another part. So really an axial pump, as you can see here. Blood comes in from the apex from here. It's being pumped through an axial pump, being pushed out again in the aorta. Problem with the HeartMate 2 was the pump thrombosis, seen in around 10% of the cases. almost always leading to a change of the hardware. Third generation centrifugal, it's more so you get a more pulsatile way of pumping the blood out, and these are the ones we now routinely implant. Here, the CE mark study, well, that's the good thing or the good thing, I'm not sure if it's a good thing, but the thing with devices, that to get it registered and get on the market, different than for drugs where you really have to show efficacy compared to placebo sometimes, compared to the state-of-the-art technique. Here it's only to show that your device is doing what you're saying it's doing, and here you see the survival analysis of the HeartMate 3, and this was a kind of an estimate based on the Seattle heart failure model, where you take several factors into consideration, what you would expect how a patient would do. Well, this is of course scientifically not very rigorous, but it gives you some insight. What do you see with these HeartMate 3 LVADs, and quite a lot of adverse events, and I can also say that's what we see in our center. We see quite often driveline infections. We see unfortunately quite often bleeding requiring surgery, renal dysfunction, and also, as you can see here, respiratory failure. So there are not a few patients who really have a smooth ride getting their VAD and being discharged from the hospital. So it's really a rough ride getting patients again stable out of the hospital with a VAD. Here you can see the comparison between the Momentum trial published in the New England last year. So the HeartMate 3 was doing better. It's a little bit a difficult endpoint as they were composing it, like being free from stroke, being free from reoperation, being free from getting a new device, and based on an intention to treat analysis. And it seems that the HeartMate 3 is doing at least as good as the HeartMate 2, especially in the sense of pump thrombosis. As you can see, is much lower with the HeartMate 3. Stroke, still 10% of the patients get a stroke in the first months after implantation, so quite high. Bleeding, 1/3, driveline infections, relatively common, and that's also that before you go into such a large trajectory with these patients, that you really have to know, are they compliant? Do they know how to handle the machine? Do they know how to handle with the batteries, that they're replacing it? Do they know when should I seek help from specialist care? So they really need to understand that. So psychosocial factors really should play a role whether you decide to give patients a VAD. However, if you give them a VAD, so these are patients on the bridge to transplant and bridge to destination as a destination therapy. In red, you can see the patients alive with the device in place, and around at the first year, 30% of the patients got transplanted, as you can see here. So if you add that up, that would be that the survival is 86% after the first year. So very good results actually from the VAD support in patients with very severe heart failure with not a lot of other options. This comes again from the Thiele review in European Heart Journal, how they would handle it, how they would propose it. So if a patient comes in with cardiogenic shock, and this is specifically related to post-myocardial infarction, of course invasive angiography, echocardiography to see whether there are complications. If there's myocardial dysfunction and there are options, then the patient should be revascularized, ventilation if needed. If you can't stabilize them, then there's a class 2B, also from the guidelines, to go for short-term percutaneous mechanical support. And we talk about the extracorporeal life support, ECLS, IABP. We abandon that. If you're able to wean them after a few days of getting stabilization, that's great. If not, then depending on their end organ function and their neurology assessment, it might be possible if you perhaps go for a more long-term solution with a VAD as bridge to discovery or a destination or bridge to transplant. Well, of course, if there is severe neurological damage, then the patients cannot be helped anymore. This is the part of the diagram when there is a mechanical complication like ventricular septum defect, mitral valve regurgitation, or free wall rupture. Well, I don't have to mention that, but that has a different treatment strategy, of course. So the summary from the guidelines, IABP is not routinely recommended in cardiogenic shock, going from a 1C, eventually doing the trials, going to a 3B. I think that's the beauty of doing these trials, to really get an answer, and there are many more examples for that. Vasopressors, a 2B, and then that's the SOAP trial with noradrenaline versus dopamine, and a short-term circulatory support, a 2B recommendation. However, there are no trials yet to compare ECLS versus doing nothing in these patients. So, ladies and gentlemen, to summarize the talk, what about the new guidelines in 2016? New definition of a gray area in heart failure, the heart failure with moderately reduced ejection fraction. More trials are needed. I think what you right now see is that in the HFrEF trials are being expanded, and that also the patients with ejection fraction between 40 and 50% are included in these analyses. We talked about the position of the ARNI, the valsartan sacubitril, as an option for patients tolerating an ACE inhibitor or an ARB. CRT, a class 1 indication in the right patients. Neurostimulation unfortunately did not work. Acute heart failure we talked about. And then circulatory support with IABP, class 3 in routine use. Selected cases, yes, a 2B. ECLS to bridge to decisions, for example, for a VAD or transplant trajectory. I thank you very much for your attention.